Without any delay, let me welcome Dr. White. Dr. Rodney White is the ex-president of the International Society of Endovascular Specialists. He's director of vascular surgery and Heart and Vascular Institute at the Beach Memorial Hospital in California. He's one of the most widely, published and one of the most important and well-known surgeon in the world and in the United States of America. Welcome, Dr. Rodney White, and we can see your slides, and let's go ahead with your presentation.
Thank you very much. It's a pleasure to be here. The first talk you asked was about progress in the ascending aortic graft space. My talk, we are using a Medtronic device here. We don't get any reimbursement for that, but that's the only potential conflict. At the current time, we've got a physician-sponsored IDE where I'll show you we've been able to look at 4 to 7 year stability healing across various lesions, as I'll show you. And there are many other centers that are coming up with similar sorts of data. Now, as we all know, the ascending aorta is a different and more challenging territory. There are very high pressure outflow areas in the ascending aorta. We have the branch vessels to deal with. And one of the questions is, can you actually hit these challenging anatomy? We had applied to the FDA about 7 years ago for what's called a physician-sponsored IDE, where we can use devices that are not commercially available for these applications. And that was to look at Valiant thoracic devices in tubular lesions. What that means is it's very hard to get an aneurysm that has adequate landing zone in the ascending aorta, or the diameter is too big. And really the challenge was first just to look at deployment accuracy, what's the stability of these devices in the ascending aorta, and then how do they remodel. We had a range of devices from 40 through 80 millimeters and went from 24 up to 46 millimeters in diameter. And we were indicated for treatment, again, of everything except for ascending aneurysm. And the way these technologies work are very similar to what you've been looking at, the TAVI cases you just talked about, where you lay it out exactly the same. You want to be able to put these devices directly above the coronaries in a controlled fashion and obviously land before the innominate. Since 2013, we've treated 12 patients, 5 pseudoaneurysms, 3 intramural hematomas, and 4 type A dissections. All of these have to be grade 4 to 5 high-risk patients. And out of that, since we've had some delays in institutional transfers, most of these have 5-year or better follow-ups. We use the TEE a lot. Be able to line this up. This is a patient with an intramural hematoma. You can see here is where we want to land the device on the other view. And then what it looks like after we've placed the ascending endograft. Here it is in position. This is that same patient 4 years later, and you can see it remains in the same place, and the aorta is fully healed with the remainder of that intramural hematoma treated with another device. Another patient with a post-surgical pseudoaneurysm. 4 years later, this is how it has remodeled. There's still a little bit of blood clot in there, but it's completely excluded and again stable. It's another pseudoaneurysm, serial images, and if you look here, and these are then the sequential imaging out to 7 years, it's remained, again, very stable and healed without any problems. Ascending dissections are a very challenging area for all of us. The red is blood flow, the blue is the false lumen. And in this patient with systole, a very small true lumen, so he was an aortic collapse when we took him to the OR. This is the TEE and how we select them. The same as you do it to line it up for a coronary or for an open case. And here you can see there's an adequate flap to be able to deploy that device. So what we do then in that case is here with that landing zone. This is on the other view just to make sure that coronaries are intact. And then what it looks like on a standard angio, we want to make sure it connects through the brachiocephalic vessels because we're relying on that for perfusion later. use the IVUS. Here we are, the coronaries with the ultrasound in the dissection, and then up to the brachiocephalic vessels to ensure they come off the arch as we mentioned. And then after deployment of the device. So here, a coronary with the device directly above that, and expansion, and you can see there's much more rapid flow through that false lumen. On this particular patient, here is the post-op TEE, so you can see it's evened out, that flap has been treated. Here it is again on another view. And on the axial, to be able to see that we've got continuity without any kind of flow around the device. This is that same patient just passed up on you there a year later. So here's continuity into these vessels, and then the descending dissection can be treated at another setting. Here's another patient on a MR, an acute dissection, treated again. This is a 4-year follow-up on that patient, again, stability in that dissection, and one that occurred after a TAVI valve with an ascending dissection. So what we've learned from all of this is a paper that's summarized at my partner, Dr. Kornizad, in Journal of Vascular Surgery. And when you look at this, the feeling is about 30% of these ascending dissections might have morphology that would fit for an endograft. So this is a very appealing technology in these very high-risk cases. And when you do them, they're over very quickly. Another report from Roselli where he treated 9 of these and also had very similar outcomes. So our preliminary data really shows that in these tubular lesions, we can deploy it accurately. The issues about migration and fixation, we've not seen either of that. And as time goes on, we're going to be able to treat more and more of these patients. I will stop a share here for a moment and then go to the second set of slides, Dr. Khanna, if you want me to do that.